Cardiology Update viewers and listeners. My name is Chadi Alraies. I'm Director of the Cath Lab and Interventional Cardiology Research at Detroit Medical Center. ACC 2023 just concluded last Monday and was done and completed at New Orleans in Louisiana. There was a lot of trials to cover. There was a lot of good science presented. And today we're going to just go over the summary of the kind of top 12 or top 10 trials that have been presented there that I think going to change or have an impact on the practice we do currently in cardiology. Starting with the first one is BioVasc. This is a very interesting article and trial because it's answering a question that has been building up over the course of years. So the complete trial is people who, just to give you some background, the complete trial looked into patient who has multi-vessel disease, came with ACS, and we were debating whether to do the culprit and complete revasc for the rest of the arteries or stage the rest of the artery at a later time. So there was other trials came and answered the question, no, we should do complete revasc definitely, but the timing of complete revasc was not sure. So the BioVasc come to answer that question in terms of doing immediate complete revascularization and before the patient leave the hospital compared to somebody can wait beyond 30 days. And it's interesting finding there was no difference in terms of target visual vascularization, MI, or urgent for revascularization. But even immediate cardiac revascularization was associated with better reduction in MI and unplanned lesion reduction or revascularization. I think this is a very important trial and kind of emphasize on the fact that maybe if the patient creatinine allow complete revascularization before the patient leave the hospital, we should definitely do it before let this patient go. I think this will kind of be slowly incorporated in the guideline, upcoming guidelines, either European or the American College of Cardiology, American Heart Association. But at the same time, it's going to take some time because it's a smaller trial, but good enough to complement what we had known before. The next trial is kind of moving from complete revasc going to surgical outcome. This is a UK Mini-Mitral trial. In this trial, the study compared minimally invasive mitral valve repair compared to conventional sternotomy mitral valve repair. And again, this is a repair of the mitral valve, not replacement. And at the end of the study, the main outcome or the main primary outcome in this trial is recovery of the patients, meaning is minimally invasive will let the patient recover faster and leave the hospital sooner and will be more functional, or the sternotomy is the same thing. And compared to the sternotomy, that is traditional approach to this kind of surgery. And they use multiple scores to evaluate the functional capacity, to evaluate the patient recovery, and so forth. But there was no difference in terms of recovery at 6 weeks comparing minimally invasive mitral valve repair compared to traditional or conventional mitral valve repair. Again, another complementary trial to kind of complement what we know about these studies. And again, there was no transcatheter option in this trial. It was completely surgical repairs. Again, great trial, well executed, and the results are promising. The next one is moving from surgical to structural heart, which is the Evolute. In the Evolute trial, this is comparing a low risk. Again, I want to emphasize this is a low risk surgical patient who have an STS score less than 2%, meaning annual mortality less than 2% for aortic valve replacement, who underwent transcatheter based therapy compared to placed supraannular compared to traditional open heart surgery. Again, the outcome here was looking at mortality, stroke, bleeding, pacemaker, transfusion, and for sure hospital death. And interestingly, there was less myocardial infarction, less hospital death, and less stroke in the transcatheter. And we know we have this trial before answering the question for Evolute for low risk patients, but this is the supraannular implantation demonstrated significant improvement in valve hemodynamics because we are implanting the valve higher. That improved the hemodynamic, and this is lasted for at least for 2 years after implantation, which is really promising. And this can speak, again, it's not 100% sure, can speak to the durability of the valve at 2 years as well, because we know the valve get used over time, and there is questionable about durability if these bioprosthetic valve we implanting transcatheter based therapies going to last long or not. But again, this fine tuning skills in terms of implanting the valve supraannular does improve the hemodynamics. And I think the trial is going to have a follow up for in terms of durability for this technique in 5 years as well, which I think going to add a lot to what we know about it now. The moving now from transcatheter therapies, moving now to the heart failure management. And I would like to introduce the trial, which I think is really very interesting. It's Better Care HF, or Better Care Heart Failure. And this is an automated patient-specific electronic medical record where it's prompt automatically prescription for a mineralocorticoid receptor antagonist for patient with advanced heart failure. And indeed, there was improvement in terms of outcome of these patients. They have been prescribed more mineralocorticoids, rightfully so, because the system is automated to prescribe when the patient running out and remind them to pick up their prescription, which I think number needed to remind was at around 25 patients you need to improve the outcome of heart failure and readmission. Interesting. More technology. I think we are in the era of artificial intelligence and so forth, and especially for patients with heart failure and readmission, it's a big burden on the health system, and I think this is an important idea. Moving along from there, again, also on the heart failure, which I think is very interesting trial, is the BMAD. The BMAD trial is examined the wearable sensor detecting the fluid build up in the lungs. So this is a new technology. I mean, I use it right now in my practice. It's developed by the company called Zoll. And this device is kind of wearable. We give it to the patient for 30 days. We're under their armpit, a little bit close to the nipple, and send the patient on heart failure management. And it will measure the impedance of fluid, how much is distance between the device and the lung, and if there is any buildup of fluid or pulmonary edema, it will alert the provider that this patient is building up fluid. Maybe it's time to give him a call, double their diuretics, and so forth. And indeed, in this trial, there was an absolute reduction of, as well as relative reduction of readmission and hospitalization for patients with advanced heart failure. I cannot emphasize on the fact that length of stay, readmission for heart failure is a big burden on healthcare. And right now it's the main focus, especially in patients with heart failure. So this device comes perfectly to help us gauge and manage these patients at home before they come to the hospital and prevent that readmission. A great, again, a trial. Moving again from there and back to the structural heart is the COAP trial. As we know, the COAP trial has been presented 3 years ago and comparing transcatheter edge-to-edge mitral valve repair, or what's called TEER, compared to medical management in patients with advanced heart failure. Now, at ACC 2023, they presented a follow-up study comparing that two intervention, which is optimal medical therapy compared to valve surgery, transcatheter mitral clip device, and overall there continue to be the same signal: less rehospitalization for heart failure, less death, and also less requirement for any reintervention in the patient who received the mitral clip. It's a complementary trial. This is a follow-up trial to what we know already before. But again, it's a really important trial to know that what we are doing and what we have done before is still helping the patient with severe mitral regurgitation with heart failure. Moving from there is to another trial, which is REVIVE-BCIS2. And I think this is a very interesting article and paper. I watched it presented as well as I had to really read the paper itself, because it's really answer a very important aspect of what we do to patients who have what we call stable ischemic heart disease patients who have a viability study confirming that these patients are viable OSCAR, and they did that by doing echo or MRI in variable degree, and compared to medical therapy. And the primary outcome is all-cause mortality, hospitalization, heart failure, because we know if we let this patient go without PCI or revascularization, especially if they are viable. The hypothesis is maybe PCI can help. However, the outcome was kind of striking and very important. And here, there was, although they were hibernating myocardium on the viability study that was seen by MRI, there was no good. There is no difference in outcome between the two intervention, meaning between PCI and between optimal medical therapy. Again, optical medical therapy, and it was very close. Was, I think, the primary outcome was 37.2 in the PCI group compared to 38% in the optimal medical therapy. But I would like to emphasize on something. Patients who are enrolled in trials, for such trials, for optimal medical therapy, they are really watched closely, and they are slowly upgrading and titrating the therapy closely by have a close follow-up with a cardiologist to maintain that optimal medical therapy all the time. Now, is this replicable in the current practice? Maybe. Some patients are compliant. Some patient shows up to their follow-up appointment regularly and religiously. But the problem when you take these trials and implement it in practice, the challenge of access to healthcare, the challenge of cost, the challenge of being compliant with the medication and compliant with the diet is compromise the outcome. So therefore, very important trial to say that patients who have hibernating myocardium or viable myocardium, optimal medical therapy do as good as PCI, but at the same time, we have to take that with a grain of salt when we implement this in practice and make sure this is going to happen as well in real life. Great trial, and congratulations to I think this is one of the highlights, in my opinion. This is the biggest highlight at ACC 2023. Moving now from PCI heart failure to atrial fibrillation and electrophysiology, and the trial called Pulse AFib or Pulse AF. The Pulse AF, they used kind of a novel, irreversible electroporation energy technology. And pardon me because I'm not an electrophysiologist, but the technology seems like very slick, is easy, and they are looking for safety mainly. It's a safety outcome of this device and efficacy in terms of keeping the patient out of AFib compared to conventional atrial fibrillation ablation procedure. And indeed, the new innovative way, what's called PFA, may provide shorter and safer procedures and similar efficacy. People who underwent this procedure, they continue to be out of AFib similar to the conventional, but it was shorter procedure and also safer with less bleeding and perforation as well. So great trial in the AFib and also our, as we call them on hashtag on Twitter, the EP peeps. Great trials. I mean, congratulations. But again, what is the cost of this technology, how we can incorporate it in our practice, I think this is an extra layer we have to investigate and study in the future. The next one is the trial, again, going back to PCI and intervention, is the RENOVATE-COMPLEX-PCI. This has investigated the use of imaging. So this is a very important trial because we always emphasize on the importance on physiology and imaging for PCI, or what's called optimized PCI, meaning are we giving the patient the best PCI outcome after they leave the cath lab for stenting. And the best way we know from Diamond trial and other trials has been shown that definitely if you do imaging before and after PCI, your outcome is better. You have less target vascularization percentage, less MIs, and definitely more durable result and less revascularization in 1 year. So now comes to RENOVATE-COMPLEX-PCI. This is investigated the imaging guided PCI, whether it's intravascular ultrasound or IVUS or optical coherence imaging or OCT to guide the management of patients with PCI or undergoing PCI. And this is a good two-year follow-up study. And then when they found is no surprise in patient with complex, meaning when they define complex, I think the lesion type was C and above, calcification, bifurcation lesion, patient who has a severe angulation. So this is a complex case, it's not just straightforward. The complex underwent PCI, the use of either imaging, IVUS or OCT. So they did not prefer either modality. So whatever you have in the cath lab is good for you. showed lower risk of death, lower target visual MI, and clinical-driven revascularization by 36% in the imaging compared to versus reduction by 36% compared to angiographic PCI. Again, I cannot really emphasize, and this is what we teach our fellows in the cath lab. We want them to use more imaging before and after PCI. Before, because it helps you to characterize the region better, as well as sizing properly. And you do it after to see you are optimized in terms of. I tell them always remember the four things: and stent expansion, stent apposition. There is no geographic miss, and there is no edge dissection. Always keep that in mind after PCI. And it's important to, once you feel comfortable, when you leave this patient, let them go and getting discharged, you feel you give them really a good job in terms of optimizing their PCI. Great study. Congratulations. No surprise with the outcome. But again, this is an extra reassurance for people who still don't believe in imaging. They have to practice image-guided therapy as well. Now, moving back to structural heart, I think this is the first time presented in terms of transcatheter therapy for patients with severe tricuspid regurgitation. And I would like to emphasize a severe symptomatic tricuspid valve regurgitation. This is the TriLuminate trial. This is a study done and sponsored by Abbott. This is for a device also similar to what we mentioned in the co-apt, is that it's a mitral clip. This is a tri-clip, tricuspid clipping, sponsored by Abbott company. And this is comparing patients who have severe symptomatic tricuspid regurgitation to medical therapy in patients who have heart failure. And at 1 year follow-up, the primary outcome of all-cause death, heart failure, readmission, and was much better in the patient who received TEER for the tricuspid valve compared to medical therapy. Again, an extra and a new development in the transcatheter therapy that's been in the market for a while, but never been studied in a randomized fashion. And this is the first trial to assure that this is a new technology that can be acquired. And I would like to mention something about the tricuspid valve because we call it the neglected valve. Even in the guidelines, when you have a severe tricuspid regurgitation, there is no indication, 1 or 2 level, to go and fix the tricuspid valve. It's always 2B because there's no enough evidence to fix it, unless you have another reason to do sternotomy and open heart, either to fix the mitral valve or to do a CABG procedure. Then you can fix the tricuspid valve. But currently, as of now, the guideline do not recommend routine tricuspid regurgitation for patients with severe TR, but now this trial comes that it is a less invasive and it is effective therapy for patients with severe symptomatic tricuspid valve regurgitation. Moving to the next the final trial, which is the clear outcome trial, so to study the treating of high-risk patient unable to tolerate statin therapy. This is a new therapy. We know statin has been known for lipid management, and now we had recently 5 years ago the PCSK9 injectables. Now the clear trial is studying the bempedoic acid for patients with hyperlipidemia and the incidence of outcome in terms of major adverse cardiac events similar to other statin therapy and prevention therapy. These and compared to placebo, and for sure, bempedoic acid was effective in reducing cardiac events, MIs, but there was a higher incidence of rise in the creatinine and uric acid and hepatic enzymes in patients randomized to the medication. The paper published in New England Journal of Medicine, it's very promising therapy available right now. I'm not sure about health coverage for these patients, but again, it's an extra therapy for prevention. Number one, primary prevention for patients with had no history of any cardiac events, but also secondary prevention, which is more important in patients who have severe CAD and underwent intervention. This was a long video. I hope you stay tuned till this moment, but we tried to bring you the summary of ACC 2023. It was a very rich, busy meeting, a lot of trial presented. This is that top pick from the Cardiology Update friends. Hope you enjoyed it. Please share this video with your colleagues and let us know in the comments if you have any suggestion. Thank you again for being with us, and we'll see you next month.